Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 42 of the Strokecast. Meet stem cell researcher Dr. Dileep Yavagal. Back in episode 35 in October, I talked with Strokecast regular Dr. Nirav Shah about the general state of stem cell therapy for stroke survivors. Afterwards, Nirav connected me with the lead researcher of the University of Miami's stem cell research team, Dr. Dileep Yavagal, so I could talk to him directly about his research. And that brings us to today's episode. Dr. Yavagal specializes in vascular neurosurgery. That includes procedures like thrombectomy, where a doctor inserts a catheter into a blood vessel in the groin to go up into the brain and pull out a clot that's causing an ischemic stroke. Mechanical thrombectomy can be done up to 24 hours after the stroke symptoms begin, based on the latest standards published by the American Heart Association, and it can have a tremendous impact on minimizing the damage from an ischemic or a clot-based stroke. And that is just awesome. But what it doesn't do today is help patients recover from the stroke. It means that fewer brain cells die, but the dead and damaged ones don't really get any help from the thrombectomy. When we say time is tissue or time is brain, which is phrases we talked about a lot with Dr. Kimberly Brown a couple of weeks ago, this is why. You see, every minute that a clot blocks a blood vessel, more brain dies. To recover functionality today, we rely on neuroplasticity. Physical therapy, occupational therapy, speech therapy, home exercises, eStim, SSRIs, even things like acupuncture and more therapies are all about encouraging the brain to rewire in such a way that we can work around that dead spot in our heads. But what if there was another way? You see, that's the question that stem cell therapy tries to answer. Stem cells, as you may recall from my chat with Nirav, are cells that can become other cells. Embryonic stem cells are the ones we hear about most in the news, but those aren't the ones being used in the trials today. Embryonic stem cells are, of course, critical in embryos because those stem cells turn into all of the other cells in our bodies. Nerves, muscles, brain, heart, left pinky, everything else that makes up who we are. The thing about stem cell therapy today is that it's not just embryos that have them. Adults have stem cells too. The most common source for adult stem cells is our bone marrow. That's the soft tissue inside many of our bones where the body actually creates new blood, literally new blood. Research is now looking at how we can use the stem cells from our marrow to drive the growth of fresh neurons in the brain. There are two major approaches to the research today. The Stanford study demonstrated the safety of its procedure in a small study, but more work needs to be done to test the effectiveness. That's the one that we've heard the most about in the news. That process also focused on chronic stroke survivors, those who are several years post-stroke. In that study, researchers drilled a hole in the skull to inject the patient's own stem cells into the damaged areas. Results are preliminary, but promising. Dr. Yavagal's work at the University of Miami is different in several ways. First, his work is focused on using stem cell therapy within the first couple days of the onset of symptoms instead of several years later. Secondly, his work relies on donor stem cells, since the patient's own stem cells are simply not available in quantity right after a stroke. It takes time to extract them from the marrow and get them ready to be used in therapy, and right after a stroke, there are higher priorities going on in trying to get that person stable. So his work uses donor cells. Third, his procedure involves delivering the cells to the brain through a catheter, similar to that used during thrombectomy or that might be used to repair an aneurysm in the brain. His results are also quite promising, and he's preparing the next phase of study to move the science along and develop safe, effective treatments using stem cells that can help patients not just not lose functionality, but to actually recover functionality. The key question we always ask, of course, is when will this therapy be available? The answer is we're not there today, despite the clinics popping up claiming to offer the therapy. However, it appears we are just about 2 to 3 years out if things go well, or potentially 4 to 5 years out if they don't. And considering the pace of change in the medical establishment, that is practically tomorrow. Dr. Dileep Yavagal is the Director of Interventional Neurology and Co-Director of Neuroendovascular Surgery at the University of Miami and Jackson Memorial Hospitals, and Clinical Professor of Neurology and Neurosurgery at the University of Miami School of Medicine. He's recently been appointed to lead the neurological cell therapy platform at the Interdisciplinary Stem Cell Institute at the university. Dr. Yavagal is an international thought leader in endovascular therapy for ischemic and hemorrhagic stroke, as well as a pioneer in the translation of intra-arterial delivery of cell therapy for stroke. He was the national co-PI of the first U.S. multi-center clinical trial of intra-arterial delivery of autologous bone marrow cells for ischemic stroke. The program was Recover Stroke. He was on the steering committee of the Swift Prime and Mr. Rescue platforms, both landmark randomized clinical trials of endovascular stroke therapy. He co-authored the landmark 2015 American Heart Association Endovascular Stroke Therapy Guidelines, as well as the recent groundbreaking DAWN stroke trial in the New England Journal of Medicine. He is the founder and past president of the Society for Vascular and Interventional Neurology. He has also co-authored the American Heart Association Policy Statement on Stroke Systems of Care. Dr. Yavagal has received several state and federal research grants to study endovascular stem cell therapies for ischemic stroke using small and large animal models of stroke in his research lab. He is considered a pioneering researcher in the field of intra-arterial delivery of stem cells in stroke therapy. So now, let's meet Dr. Dileep Yavagal. So Dileep, thank you so much for joining me here on Strokecast this week.
It's really my pleasure, Bill. Thanks for inviting me.
Yeah, I'm excited to talk about the research and the work that you're doing. But first, how did you get into neurological and stroke recovery research?
I went to medical school in Mumbai, India, in the early 90s, and I did internal medicine residency in Mumbai, where I saw a lot of stroke patients and got very interested in both neurology and cardiology. But then I wanted to train in the US, so I came to the US in 97 and went to Harvard for neurology once I decided that I was going to pursue neurology rather than cardiology. And one of the reasons I chose neurology was there was so much research that was really still to be done in terms of even starting to treat stroke. That was such a major need as compared to cardiology, where there were already procedures to treat heart attacks and such. So I was very fortunate to get to Mass General and Brigham and Women's, where I got very interested in stroke as part of the neurology training. And as I was in my second year of neurology residency, one of my attendings there, he asked me to write a chapter on cell therapy for stroke. It was really pretty interesting topic at the time, and I had no idea at that point, but did the research for the chapter and got my first introduction to cell therapy just in general, and then that remained in my in my subconscious as a very exciting possible novel treatment for stroke. And I went on to do interventional neurology at UCLA, which is a new specialty for neurology that really has changed the way we treat stroke. And at that time, there was promise. There was nothing that was established as a possible therapy to reverse stroke, but there was a lot of promise with neurointervention. So I did a fellowship in neurocritical care at Columbia, and then did a neurointerventional fellowship at UCLA, where I was again very fortunate to be trained by one of the pioneers in neurointervention, who allowed me to develop a large animal stroke model during my fellowship to test new therapies. By the way, the faculty at Mass General who inspired me and got me into reading about cell therapy for stroke and writing about it was Seth Finkelstein, and he's still pretty active in the field. But in any case, when I finished my fellowship and a couple of years later got recruited to the University of Miami, the main thing I had to decide at the time was what new therapy am I going to test in my large animal model? And the University of Miami had just established a stem cell institute. So it was kind of a full circle at that point, where I had gotten interested during early training in cell therapy, and now there was a very huge resource that was right there that was not common. There's only about 10 or 15 cell therapy institutes in the US. And I, again, found a really good mentor who's a cardiologist here who is an expert at cell therapy, Dr. Josh Hare. And I combined forces with him, got grants, and started studying cell therapy, both in rats and in the large animal canine model, and saw a fantastic benefit in these stroke models. So that's where I got really going with doing early clinical trials of cell therapy. And I was fortunate to be asked to co-lead the first randomized trial of giving cells through the carotid artery with catheters into the brain in 2011. It was an industry-led trial, industry-sponsored trial, I should say, Recover Stroke. And we did the first randomized trial and showed that to be safe. And so that's the sort of journey in the nutshell. I'm continuing to do both the lab work and the clinical trials for cell therapy for stroke patients.
Well, that is fantastic. I think what's really amazing is that you know, when you talk about about starting that study in the US in 97, 20 years ago, there really weren't the options for treating stroke survivors in the ER, and even in early therapy, there really wasn't as much knowledge about things like, neuroplasticity as there is today. And the field has really changed dramatically in that time. So as you're doing more with the stem cells for stroke recovery and helping people potentially get more functionality back, what is the theory behind using stem cells? Why should they help people recover functionality after a stroke?
Yeah, that's a great question. So the entire field of stem cell medicine, which is also called regenerative medicine, was initially based on the premise and findings in the laboratory that these cells, which were initially derived from sources like the embryo or fetuses that were discarded or other types of cells, these cells divide into all three main type of tissues in the test tube: the endothelials, the epithelial cells, which also which also form the brain, the mesenchymal cells, and the endothelial type of cells. And that capacity to transform into all types of tissues really suggested that these cells could be used to replace injured tissue and injured organs. The most promising clinically applicable type of cells obtained from the bone marrow, can be also obtained from the umbilical cord or from fat. And these cells are much less controversial from as far as their source is concerned. And these are extended into massive amounts to be widely used clinically. And that is very well established, very feasible. So the industrial application of cell therapy is best done with these adult stem cells, is what we are now. And where the field has moved as far as bringing cell therapy to patients. Now, why or how these adult stem cells work is actually quite a bit different from what the initial premise was. These adult stem cells also differentiate into all three main types of tissue. But when you give them in a patient for either stroke or heart attack or other injury, they act like drug factories that secrete pair molecules, injury prevention molecules, anti-inflammatory molecules, and I'm using lay terms. These are called cytokines and growth factors. But anyway, they are essentially molecules that these cells secrete in response to injury. That's the really neat feature. And they essentially act to repair these tissues. And this occurs even naturally. In other words, when an injury occurs, when a stroke occurs, these are the same cells from our bodies that go and lead to repair. But this repair is partial and incomplete most of the times, depending on the extent of injury. The larger the injury, the more incomplete the repair. When you give them from outside, you can give them you can give a lot more. And so essentially the approach in concept is to enhance Mother Nature, enhance the biology of repair by giving these cells. And there is a good amount of evidence that has accumulated over the last 15 years in the laboratory, proving that this is really the mechanism of benefit. And so this is how cells lead to recovery in stroke also, when we give them in stroke patients, I should say.
And since they come from the patient's own body, that also then seems like it makes it less likely that the body is going to reject those cells or attack them with its own immune system like they might with cells that come from another source.
As it turns out, actually, if these cells are given early, especially in stroke, they have a much stronger benefit. It's logistically and medically difficult to get it from patient's own bone marrow, and it's impossible to expand them per se. You need large quantities, and therefore these cells need to be expanded. So, approach of using a healthy donor, where these cells are already expanded and kept on the shelf, was looked at, and it turns out because these cells are very primitive, they actually lack the antigens that lead to rejection. And so their biology, their innate biology, actually allows for giving cells from healthy donors without matching, without doing immunosuppression. And so that is coming to the fore as possibly a better approach. And people are comparing autologous to allogenic, but my own approach in the laboratory and in the next trial that I have proposed and applied for funding is allogenic, where we have cells from healthy, young, healthy bone marrow donors, 18 to 40 years in age, who have been tested, and things are all according to standards. But the biggest thing is that these cells are already expanded and ready to go on the shelf like medications, and we give them very early in the stroke, like around 24 to 36 hours.
That's fascinating. It's amazing how much stuff happens so quickly after the stroke, when the brain is sort of going into that initial mode of trying to recover and repair and do all of that stuff, and getting that early intervention is really, really fascinating. So you've talked about some of this, the other research you've got coming up, and I think a lot of where people have first heard about stem cell research, what's made it down to a little more of the mass audience and some of the stroke groups and support forums, has been the early results that have come out of the research the folks at Stanford have done. What's different in the approach that you're doing at the University of Miami versus some of the work done by other research teams?
My approach has been to deliver these cells inside the artery going to the brain in a stroke patient, rather than drilling a hole and giving cells directly into the brain tissue with needles and such, or giving cells just through the vein, IV. And the optimal route of cell delivery has not been established. And there also may be more than one route of delivery that could be combined. But the reason I focused on what we call intra-arterial delivery is for two reasons. One is that is my clinical field of practice. I do surgeries in the brain for stroke from inside the arteries using devices and catheters. And this has, as you know, become the standard of care approach for acute large vessel stroke, where we do a thrombectomy from inside the blood vessels using a device. And so the clinical translation of adding cell therapy via the same approach is very attractive and very logical, but also my research dovetails with my clinical practice. But the other big reason is more biologic. It turns out that whereas we don't know this 100%, a lot of what we know points to the intra-arterial route being probably a very good one as compared to giving cells IV or giving cells directly into the brain. When you give cells through the IV, is 95% of them get caught in the lungs and the liver, because these cells are, they're relatively big in size, and the natural filters of the body, they catch them. Even though they don't reject them, they catch them, and very few cells get into the brain. So for stroke, if we look at the evidence where getting cells into the brain is important for repair, the IV route certainly allows only about 3% of cells get into the brain, and that too after like 3 or 4 days. And when you give cells directly, you can get them there right away. But because you're giving cells into the brain tissue, which is like jelly, these cells remain localized or remain restricted to the few millimeters area that you've given the cells. And so you may have to poke a number of holes to cover even 10 to 15% of the stroke area to distribute these cells. What happens when you give them intra-arterially is now you're using the natural route of distribution that the body uses. And these cells, they are alive, and they, in the early phase of stroke, in the first 2 to 3 days, they get out of the arteries into the stroke area, because they are attracted to the injury molecules that are secreted. Remember, I said these are the natural repair cells. And so you can get almost 20 to 30% of cells that you give into the carotid artery into the stroke area when you give them intra-arterially. And so that has a lot of biologic rationale, a lot of reasoning that's very solid to give the cells through this route and effect, the maximum recovery possible. And also, as compared to the direct stereotactic approach where you have to drill holes in the skull and poke into the brain, this is obviously much less invasive. So that's what I focused in at the University of Miami, and we led the Recover stroke trial along with the UT Houston and showed that this route was safe. We had the trial stopped at 48 patients. It was planned for 100 patients. Because of funding issues, it stopped at 48 patients, and we have met the safety endpoint. The patients were too few to really show a difference in efficacy. But certainly there were no adverse events of concern when we gave cells through the carotid arteries using catheters on the side of the stroke. So that's what we've been studying and bringing to the fore. That's different from Stanford. They have been using the stereotactic approach, and they do it in more chronic stroke a few years out from stroke, and we are doing it in the first few days.
Fascinating. And from a patient perspective, I mean, just the idea of hearing about these different approaches, the idea of sort of going through the circulatory system the way food and oxygen and everything else gets delivered to the brain anyway, certainly sounds a lot more appealing than having a hole drilled into my skull in the middle of a traumatic event. So as you move out of the phase of the research about that established safety, what are you doing in the second phase, in the next step of the research with your next round of patients?
The first trial, what we call phase 2A trial, that established safety of this approach. The next study really needs to show at least initial benefit to move this therapy forward to bring it to patients. And so the next study, we're calling it STEM stroke. And there, instead of a small number of patients, we are proposing 150 patients that will again be randomized to getting cells after a stroke within about 24 hours. The first study was at 2 weeks where the patient got cells because patients had to be stabilized before we got bone marrow from them. This study will be what we call a allogenic cell therapy study where the cells are ready to go and they're obtained from healthy donors. So we can give them at 24 hours up to 36 hours. And these cells will be again given through a catheter that's introduced through a groin incision or a small wrist incision, and the catheter is navigated all the way up into the carotid artery that's about to enter the brain. And so we inject these cells at that region that is similar to the first trial, but these cells will be given early. They'll be from healthy donors, and we'll have 3 times the number of patients as the first study. And we think that, again, we look at safety and efficacy, but we'll have what is called the power. It's a statistical term, as you may know, to see if there is indeed a benefit in patients getting the cells as compared to the patients getting placebo or sham surgery in this case. So we are applying for funding actively with the NIH right now. We're also applying to industry as a backup, but that's the plan, is to do a larger trial and give the cells much earlier.
So assuming the trial goes well, obviously a lot of folks out there who are survivors are already asking, there's been a lot of attention in the media. There are other places popping up on the internet in this country, and if you wanted to fly around the world to get stem cells. But assuming this study actually goes well, when do you think there might be available for actual clinical use as a procedure available to survivors who want to recover more of their function?
Yeah, that's a great question. And as much as we want to get this to stroke patients right away, The steps just take time, and they're obviously there to ensure patient safety, and that we are not applying sort of futile therapy to a large number of patients. But I would estimate that we could have this therapy given to patients even in the next 2 to 3 years. If it's not the approach that I'm pursuing, one of the big studies that Stanford is pursuing is announcing results early next year. And if that shows benefit, then in chronic stroke survivors, so not in the first few days, but months to years out, the approach of giving cells through a small hole in the skull could be available to patients for improving recovery. My own approach, I think, is at least 2 years away. And the other good news is that the FDA has modified the pathway somewhat for cell therapy, and they are trying to hasten the pathway to bring it to patients. So they may not need 2 studies that are very, very large and other such requirements that they usually have. So the FDA has developed a fair amount of confidence in cell therapy as an approach. And I think it could be as early as 2 years, but it could be 4 to 5 years also. So that would be my estimate.
That is fantastic. For a lot of things, it seems like that's a long way off, but for major interventions and major changes in the medical field and new things, that really sounds like it's happening fairly quickly. And it's great that so many folks are behind that. And the key thing there is that while this research is really promising, it's not there today, but soonish.
Correct.
That's fascinating. And if folks wanted to learn more about stem cell therapy and what's happening in research, where should they go, or what resources should folks outside the medical field be looking at if they wanted to educate themselves more about what's happening?
The clinicaltrials.gov is a very good resource for looking at what active clinical trials are going on in cell therapy for stroke. I mean, it's a repository, online repository for all clinical trial studies. These trials are put into this repository from all over the world, so patients may not necessarily be able to access them because a lot of times the entry into these trials is depending on the country funding these studies. But nevertheless, at least one can get an idea of what trials are going on. And then there is just a very mixed level of information on the World Wide Web, which can be misleading in terms of the promise and this therapy being available right now, right this minute for benefit. I think I would caution that any such approach be verified either with a U.S. Academic doctor that pursues stem cell research, or look it up in this resource called PubMed, PubMed.com, and see if there is what's called peer-reviewed literature on such an approach. But obviously, the FDA is really the single regulatory body that lets everyone know what is approved and what's not. And what's not FDA approved is always tricky to pursue outside of clinical trials. In clinical trials, everything is regulated. There is a lot of oversight. And so at the least, things are, the risk is lower of something egregious happening. And so I would say clinicaltrials.gov, PubMed.com, and the FDA are your trusted sources. I would caution, especially standalone stem cell clinics, either in the US or outside. Not that their intentions are in question. They want to do good for patients, but we are not there where we can apply this widely just yet.
Oh, that's an important consideration. So, Dileep, thank you so much for the work that you're doing. I know I and other survivors appreciate it, and folks who have not yet had their stroke are very much going to appreciate it in the coming years. Thanks so much for joining us here on Strokecast today. And yeah, this has been fantastic.
Well, thank you so much. I really appreciate the opportunity and happy to come back in the future with any updates.
And that brings us to our hack of the week, gift bags. As we head into the gift-giving season, we have to start thinking about how to wrap presents. Wrapping paper is great when you have two functional hands, or you want to use some sort of gift wrapping service, or you just want to have something that's easy to throw at the cat after you unwrap the present. If you have just one functional hand, though, it can be more challenging. If you want to take on that challenge, you can certainly find videos on YouTube demonstrating different one-handed gift wrapping techniques, but in this case, I prefer the simpler way. Gift bags. Seriously, make it easy on yourself and use these fancy mini shopping bags. Add some tissue paper to the bag, put the gift in, lightly crumble some more tissue paper to put on top, and then you're done. If you're feeling really ambitious, you can go ahead and tie the handles together with ribbon. And when all is said and done, you can still ball up that tissue paper and throw it at the cat. So I hope this episode has been educational for you. Stem cell therapy is getting a lot of attention these days, and it's important to keep in mind that it is still in the clinical trial and research stage. Still, there's a lot to be optimistic about. In addition to his work with stem cells, Dr. Yavagal is also one of the leaders of the Thrombectomy 2020 program, an international initiative to reach 202,000 thrombectomies a year by 2020 and to continue doubling after that. There are communities in the U.S. and around the world where this therapy is simply not available, either because the hospitals and facilities in the area don't have the skill or hardware to do the treatment, or even because there's just not enough awareness of the treatment and of the possibilities and just how important it can be. It is such an extremely powerful way. Mechanical thrombectomy can be such an extremely powerful way of reducing the disability caused by stroke, saving hundreds of thousands of people from having to deal with the deficits of stroke and saving billions of dollars a year in healthcare and disability-related expenses. We'll talk more about Thrombectomy 2020 in a future episode, but I'm really glad that folks like Dr. Yavagal are doing everything they can to go ahead and advance awareness and availability of this critical therapy. For now, I'd ask that you share this episode with someone else by giving them the link strokecast.com/stem cell therapy. Be sure to subscribe to Strokecast for free in your favorite podcast app so you don't miss an episode. This holiday season, try using gift bags instead of wrapping paper. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.